slide. And this talks about investment of projects, and that their study started in 2010, and their last study was in 2011. So in the last 10 years, there's been a marked increase in the cost of projects. So about 10 years ago, projects were costing $100K or less, a lot less risk. And now the trend is the projects are well over $10 million, as is with this health system $189 million project. So they're a lot bigger risk than they used to be. Not surprisingly, the number of employees that are impacted by these high-cost projects has gone up as well. You know, you've got the majority of them affecting less than 50 10 years ago, and now you've got them up well over 5,000 employees. Okay, so when you think of an EMR implementation, all of the people that have to change something that they do. So in this particular studies that they've done over the last 10 years, these change projects are getting bigger and impacting more and more people. So now they're impacting, the majority of them are impacting over 5,000 people at one given time. And this health system that we're looking at, it really impacted 20,000 people, 20,000 employees, which is big. So why all this change? Well, healthcare is facing a lot of pressures, which is forcing change. Again, you guys have probably seen this a lot: healthcare reform, regulatory pressures, meaningful use. You've got healthcare industry pressures and market share, patient expectations and competitive offerings, shift in Medicare and Medicaid payments, increased healthcare costs. Scarcity of human resources is really forcing process efficiencies and real-time data. Technology lifespan's a lot shorter than it used to be. You have to stay out ahead of the curve. And hard economic times. So healthcare has to address these pressures in order to survive, and it's forcing change. So did you know that emotions are contagious? You probably sort of instinctively knew that, right? They travel at a subconscious level in milliseconds. That makes them more contagious, or actually travel faster than sound or a sneeze. They're more contagious than a virus. So think about how you felt when you were watching that clip, and relate that to a clinician when you take away their paper chart and you hand them a computer. You know, and think about, you know, imagine how those emotions start to grow and how quickly that could slow a project down. How contagious those emotions are. I see lots of knowing nods. Well, ProSci and all of that research that they've done over the last 12 years, they found the #1 obstacle to the success of a major change project is employee resistance and the ineffective management of the people side of change. Does that surprise anyone? I tell you, every time I do a project, the surprise is leadership, right? Because it's not about time, it's not about money, it's not about resources. It's going to be employee resistance that kills you every time. And every time, leadership seems surprised, right? Why are they, you know, yeah, we spend $189 million. Why don't they love it, right? So change management is simply, the purpose is to keep people engaged with the change, right? That's the whole purpose of a change management program. And these are some of the really important functions of a change management program. Sponsorship and governance, development and support, that's a huge one, and we'll talk about that a little bit. Strategic planning, workflow and gap analysis, communications training. I'm not going to spend a lot of time on the functions, but what we want to examine was how effective the change management program was for this hospital system and whether they achieved their ROI. Okay, so here's some more ProSci research. Basically, on a very basic level, they found a huge correlation between change management and meeting business results. So the more effective a change management program, the more likely the project was going to be on time and meet its objectives. They had either an absence of a change management program or a poor one, poorly executed, then their objectives and schedule were at risk. So very basic, the ROI #1 of an effective change management program is going to support the projects meeting their objectives and staying on time. So that's the first ROI. Some more research. If you think about this 0 right here being your implementation, and over time, you're going to see the height of the benefit of an implementation is based on ultimate utilization, right? You want people to use whatever technology you're putting in. So the benefit is really how many people are using it and the proficiency. You want to get there faster. So the proficiency contributes to the utilization. The more proficient, more utilization. Again, doesn't seem like rocket science, but you'd be surprised. So when you apply that second rule of ROI to an EMR implementation, this is what you get. I use this slide quite a bit, actually. So here we are. This is the announcement that we're going to get an EMR, and it does everything and wash your car, right? It's wonderful. Blue sky. Everybody's going to get everything they ever wanted with an EMR. Then they go to training. Whew. And they realize, well, it's not everything they imagined it would be. It's not doing X, Y, and Z like I thought it would. But we're still pretty excited. You know, we've got Go Live coming up, and you get implementation day where there's all this hype. Everyone's really excited. You turn it on. And then the project team says, oh, phew, we're done. They leave, right? So they spend all this time selecting, building, testing, putting it in. And the minute they flip the switch, they're off the hook. The project team's like, we're out of here. The consults, they're all gone. And then the users go, OMG, right? They're like, where is everybody going? And they get into this stage called post-live anger and frustration. That's what I've tagged that. And again, it's natural. It happens every time. But again, leaders seem very surprised when it does. And really, ultimately, when I talk to people, the role of change management is to make that dip as shallow as possible. So the more effective a change management program, basically, the less post-live anger and frustration you're going to see. So, you know, remember that day, I'll never forget it, where you had charts thrown at you at implementation and people refusing to use it and swearing and putting up a big cake, dust. That's normal. And then eventually they get through that phase and you see that slope of productivity. So there again, the benefit is based on the height of utilization, and you want to get them there as quickly as possible. That's the role of change management. So again, this is normal. It's what I try to tell everybody. You're always going to have this, and you have to, therefore, plan for it. It needs to be expected. You got to plan for it. So ROI number 2. The height of benefit after a technology implementation, like an EMR, is based on ultimate utilization of the technology. Number 2. So those are two sort of general ROIs. So we're going to talk specifically about what I did with this particular health system, right? So they needed to pick what was a specific ROI for their CPOE implementation. And everybody says, oh, CPOE, we've been there, done that, it's old news. But I can tell you, the change management is still just as important now, if not ever. And some of these things we'll talk about today can be applied to your projects today. So when I talked to the leadership of this health system, I said, what does success look like to you? When CPOE goes in, what does success look like? What do you think was some of the answers I got back? Any guesses? Yeah, so we're going to save money. We're going to improve patient care and patient safety. Those are the standard answers you get when you ask about ROI, right? That's what everybody gets, and that's what I got. And I said, what behavior change are you looking for? What does an engaged user look like? What type of behaviors are you going to want to see in order to realize your patient safety improvement? And they thought about it, and they thought about it, and they said, we want physicians to enter their own orders electronically. And that was a huge, I think, a huge goal, because when you look at the industry out there, they don't really force physicians to do it. They have providers putting it in, secretaries putting in, nurses putting it in. But this health system said no. The leader said no. We want our physicians putting it in. And that's how we think we're going to really realize the patient safety and patient care improvement from CPOE. So that was the behavior change they wanted to see. They wanted to see the physicians actually putting in the orders themselves. I was really excited because first it was only one measure, right? Because before they wanted 10 measures. You know how that is. 12 measures. You've got to meet all this criteria. But it was one measure. And leadership came up with that measure. The project team didn't. so that we had buy-in that the leadership and the hospital and the clinicians were the ones that came up with that goal. They changed policy. So if physicians weren't putting in orders, that was against policy. They didn't go to training, they lost their privileges. So again, it was determined by leadership, and once they came across that measure for change management, they had to change the policy to support it. The executive sponsor of the project, actually, he was clinical, explicitly named hospital presidents as responsible for the success of this initiative. And you should have seen that meeting. It was funny because all the hospital presidents were like, me? You know, what have I got to do with it? So leadership said, we want physicians to put in orders. We're going to change policy to support that. You hospital presidents are going to make sure that it happens. And then they held their hospitals' presidents responsible for that. So these were all key components of that third ROI. So their third ROI that they were looking from a change management or behavioral change was that the physicians were going to put in their own orders. Now this is different than meaningful use. If you think about meaningful use, they don't require, meaningful use requires 30% of patients have a medication order entered electronically. So it's a little bit different than it is. It's patient-focused from a meaningful use perspective, and it has to be a medication order in there electronically, but it doesn't matter who put it in. In this particular case, it matters who put it in, because they didn't want nurses or scribes putting this in. So here's what it looked like when we communicated it. If physicians don't change how they write orders, then it doesn't matter that an EMR was ever implemented, right? Because they don't change how they write orders, then we're ultimately not achieving what we set out to do from the beginning. So they were like, well, what's the use of putting it in if the physicians aren't going to use it? So they wanted to measure utilization of the system. Like we talked about before, the height of utilization and productivity really drives that. So ROI number 3, if we're successful, then physicians will place their own orders electronically. So we had a very, I felt, effective change management program, supported our project, and we met our objectives and we stayed on time. We were driving for a very quick return as far as height of utilization and productivity. And number 3, if we were successful, then physicians were going to place their own orders electronically. So again, in asking what success looked like, okay, so that was only half of it. We said, okay, physicians have to put in their own orders. Well, what percent is going to be acceptable and what percent's not? And of course, leadership said, well, 100%. You know, we're going to have 100% of the orders put in by physicians. And of course, physicians were like, oh, what if I'm in surgery? You know, what if I'm in a ball game? So that wasn't realistic. So I had to go out and do some homework, went out and looked at the industry average. And this was in 2009, so I didn't have meaningful use to help me out with any benchmark. So this was benchmarking that we did. And we noticed in the industry, the average of orders entered electronically was about 57% in 2009. Again, this was any kind of order entry, whether it was clerk, anybody, wasn't just physicians. And then we did some chart audits, and we took a look at what percent of orders are actually written in the chart. And I said, you know, wouldn't it be nice to just convert those written orders to electronic orders? That wouldn't be a big win. And so we did a lot of pre-live chart audits, and we found that about 40 to 60% of the orders were actually written in the chart. So they weren't telephone, they weren't verbal, they were actually written in the chart. And I said, okay, well, let's aim for 60% of the orders will be entered electronically by physicians. And leadership said, that's not good enough, it needs to be 85. So they sent a stretch goal of 85% of all orders needed to be entered electronically. Now, in this particular hospital system, they have about 1.5 million orders that go through the EMR on a monthly basis. So when you think about, what is that, 85%, I don't know, I can't do the math that fast. It's more than 1 million being entered electronically, right? If I do that right. So it's a lot of orders. So pre-go live, this is what the chart audits looked like. As you can see, this is one particular hospital where 47% of their orders were written 51% were telephone, and 2% were verbal. This was pretty common, a lot of telephone orders. And then after we went live on the EMR, there was 75% of the orders were entered by physicians. We were thrilled. Leadership was thrilled. It was wonderful. And written had dropped to 11%, telephone 8%, and verbal 6%. Now, we still had those outliers of the docs that would walk down the hall, open their phone, behind a closed door and call in an order. But for the most part, it was very successful. So here are some post-go-live results. And these are real results from 7 different hospitals. And this is the percent of total orders that are entered by physicians. So Hospital A, 75% of their orders entered by physicians, and so on. Across the health system, for 1.5 million orders a month, they are at 78% of those orders being entered by physicians. So we were pretty proud of that. When you think about meaningful use, threshold only being 30% of medication order, no, 30% of patients having one medication order electronically. So they're set up really well to meet that meaningful use objective. But at that time, in 2010, we didn't know meaningful use was going to be coming down the pike. So we're in pretty good shape as far as that measure goes. But yeah, we had a very successful change management program. So ROI number 1, the change management program really effectively supported and met the project objectives and stayed on time. EMR proficiency was obtained faster. If I go back to this graph right there, those post-go-live results that ended up direct CPOE, that was 2 weeks after we went live. So it was quick. It was a very quick turnaround that we got that. And then physicians entered their own orders electronically. So it was a very effective change management approach. Here are some keys to success. When you're picking your change management measures, make sure they're the correct ones. Right out of the gate, people make a mistake with this particular one. They don't pick the right measure for ROI. They say, oh, it's going to save money, it's going to improve patient care. But you have to really push them to say, what behavioral change are you really going for here? Because we're talking about measuring change management. You're going to have your other measures. You have your other measures on medication safety. You're going to have your other measures on meaningful use criteria. What behavioral measure are you going to use? And sometimes you have to really force your leadership to examine that very closely. They need to be focused measures. You don't want them to come up with 10, 12, 15 different measures because people can't focus on that. That's too much for them to achieve. So make sure, I always say 3 maximum, but 1 is really nice. You need to make sure leadership's aligned with those that measure of ROI. Too many times the project team actually decides what success looks like and leadership doesn't. So it's very important that the leadership actually decides what is going to be the ROI. You have to make sure that people know what they're going to be measured on ahead of time. So once they decided that physicians were going to enter orders, the change management team went out and said, okay, you're going to be expected to put in your own orders, doctor. And they all went, not me, right? And they all wanted scribes. They all said, well, what happens in the middle of the night when I get a patient, admitted? What am I, I can't get out of bed. So we got up, but they were aware ahead of time what the expectation was. And we said, there's going to be policy that you have to put in your orders. And the goal is going to be 85% of your orders are going to be placed by you. So they knew it. They knew ahead of time. They were very aware of it. And that's important. It's also important to have that measure benchmarked. Whatever measure you come up with, you need to make sure it's realistic. And so you need to go out and do your homework in the industry to understand whether the measure is realistic. And then you need to report on it. And you need to report often and in such a way that it can be acted upon. So you have to go through the whole cycle. You have to determine the right measure, make sure there's not too many. Leadership has to come up with the measure. People have to know about it. The measure has to be realistic, and then you have to report out on it. So they know how they're doing, right? Can't hold them accountable if they don't know how they're doing. So one of the things we did with I'm going to go back real quick. With this report and the way we reported it, was that we had to actually build the system to be able to capture this data. When they decided that physicians had to enter orders, then we had to make sure that the physician could the system could actually capture that data, and we designed and built it that way. Then I needed to make sure that the reports were ready to go the day we flipped the switch. I had leaders asking me an hour after we went live, what does the CPOE numbers look like? And then it was important, we reported out on these on a monthly basis, and it was transparent. They went out to everybody in the organization. So one hospital saw somebody else's CPOE results, and leaders at all level. And it went out by by physician name. So you could roll it all the way down to a physician. So you could, at any given time, call up a physician and know the percentage of his orders that were entered by him, percent that were verbal, and percent that were telephone at any given time. And then you could roll it up by hospital and roll it up by system. So it was important that these reports were developed ahead of time as per policy. They were ready to go when we went live, and that the information was transparent and saved with everyone. And so each month the hospital president was expected to go in and check on their own physicians to make sure that they were meeting that 85% goal. So there's a lot of competition between the hospitals when they see that somebody else is at 88% and they're at 63%. Hospital leadership and the system leadership asks them why. Why are you at 63%, somebody else is at 88%? Thanks for stopping by.